Okay, here we are. Thanks to Dr. Ajay Mehta to allow me to talk on this great series of lectures. I've got a lot of time for Ajay. He's a top man, great work ethic. If my son works as hard as him, I'm a very proud man. Great story about his grandmother basically saying make something of your life, and before she passed away, and he's taken that to heart, and he's set up this great charity to feed thousands of children, feeding, water, helping in Corona. If you don't give back, what's it all about? Anyway, I'm going to be talking. I'm Mukesh Soni. I've been working for 30 odd years. This is when you meant to say I don't look that old, but I do with all this white hair. I've got my beer in hand, and we're going to be talking for about 45 minutes to an hour. This is a day-long lecture with some hands-on, which we'll be presenting soon. Bridge socket preservation, it's a no-brainer. What do I mean by that? It just helps in so many ways. It's not just about implants, it's about lots of other things. It's about how to look after sockets and treat sockets and to reduce pain for patients and just planning for the future. So let's get on with this. We're going to be talking about why we're going to do ridge preservation or socket preservation. We're going to talk a little bit about anatomy, just a touch on bone physiology, how we do socket preservation, and then we're going to go over some cases. I believe every dentist in the country can learn how to do this. It's minimal training. Of course, you've got to understand. I think it'll take about half a day. It's just a great something to have in your armamentarium. The also it's a great stepping stone to maybe future surgical surgery, helping with your oral surgery, and also if any further training you do. It's a great combination to have with your NHS. It's a good little money earner. We'll be touching on those things as we go along. You don't need to do ridge preservation or socket preservation. You don't need to attend a full implant course. Yeah, but it's a step in the right direction if you wanted to go down that direction. Yeah, in the future. Why? Why are we going to do this? We know when the tooth comes out in the first 6 months to a year, there's a lot of hard and soft tissue loss. Basically, and from the papers you read, it could be anything between 75 to 50% loss in the first 6 months. Okay. There's also, we're not talking about soft tissue augmentation today. We're going to talk about how to reduce the amount of bone that is lost. We can see teeth have been taken out on the top and on the top two slides, and these teeth will may find it difficult to create pontics in the future, aesthetic pontics. The way we get around it with dentures is obviously using a flange. Also, in this bottom left picture, we can see two teeth that are periodontally involved. They're on the way out, they're mobile. We know when they take those two teeth out, we're going to lose an enormous amount of bone. Is there anything we can do to try to reduce the amount of bone to make future treatments easier? Yes, there is. The bottom right is an implant case. This tooth was grade 3 mobility. It was just moving up and down, left and right. It was in a healthy state. But when I take that tooth out, what's going to happen? I'm going to lose all that bone. If I want to put an implant in, it could be very difficult. I'll have to go think about doing sinus grafting. Again, not just about implants. If we're going to place bridges, if we're going to try to get nice aesthetic pontics, when these teeth are taken out, if they're taken out for any reason, It would be great to try to preserve as much bone as possible. That would help us with papilla formation and create better bridges. This is important. This is important. So when you take teeth out, think about retaining some of that bone, some of that architecture. Again, with dentures, we can get away with that. Dentures aesthetically look fantastic sometimes at the front. A single acrylic denture, single tooth denture can look really good. Part of that is because you can cheat with the acrylic. So there are financial gains. There are financial gains. We have a lot of our ex-students who are working within National Health. They are performing extractions. They're placing Rochette bridges for anterior teeth, sometimes dentures, but now it's a lot of Rochette bridges or Maryland bridges, and they perform socket preservation, maybe getting ready for an implant in the future, or just for aesthetic reasons. They are claiming their 12 UDAs, and legally, from what I've been told, I'm not on the national, you can claim for bridge preservation separately, which could be anything by 250 to 500 pounds, depending on what you charge. Again, minimal startup costs to do this course. I'm not trying to sell my course. I'm just trying to get you geared up to try to help you in the progression of your career. If I'm talking to some young students and young dentists. Inexpensive course, minimum instrumentation is required. It will improve your surgical skill sets. There are minimal overheads. There's a high return on income. Millions of extractions are created every year. Millions. So we're just ready. We're ready. We've got the patients are there, and there's minimal complications. Let's talk a little bit about anatomy. Anatomy of the alveolar bone in a transaxial view. We have two types of bone. We have the alveolar process and we have the basal bone. The alveolar process is what holds the tooth. There are two parts to the alveolar process. The alveolar bone proper, which is the bundle bone. It is the bone that's up against the tooth. Then you've got the sporting bone. The sporting bone is the cortical bone on the outside of the alveolar process and the trabecular bone. The basal bone is anything beyond the root. That's what the basal bone is. The basal bone is very stable. The alveolar process is not. When the tooth is extracted, the alveolar process becomes the alveolar ridge. What we're trying to do is try to create as much bone in the alveolar ridge as possible. This is a picture of a skull where where everything has been turned, all the socket has been taken away. And again, we can see that the basal bone is anything above the blue lines, and the alveolar bone is anything below the blue lines. Some evidence-based stuff. We know is a classic paper. If you want to go and find it, really, if you need that paper, I can find it for you. I can send it to you. Don't ever be a beagle dog in Scandinavia. You won't last long. Yeah. But we can see that what we would love to have is that blue line for the alveolar process to stay up. But it was on extraction on these beagle dogs. It was found after 14 weeks. Well, I think it was 8 weeks, sorry, that the buccal plate, less on the lingual, less on the palatal because of various reasons, but the buccal plate disappeared. Yes, a lot of buccal plates disappeared. And that's useful in pontics, useful for soft tissue support, and also useful for implants in the future. The bundle bone, the lamina dura, and the fenestrated bone. This is the bone up against the tooth. This is an extension really of the periodontal ligament. It is a mineralized periodontal ligament. When the tooth is extracted, the periodontal ligament is removed, and that stops blood supply to the bundle bone. That means the bundle bone will disappear. If there is no bone on the outside, meaning trabecular bone, that bundle bone will disappear. On the other side, if there's no trabecular bone, which happens a lot of times, especially from upper 3 to 3, especially if the patient's had some ortho or Invisalign, and the teeth are taken out of the bony envelope, the underbone disappears. That means the buccal plate will start to disappear. The cortical bone has blood supply, most of the blood supply from the soft tissue on top of it. Hence, if you remove the soft tissue to remove a tooth, and there is no trabecular bone underneath, and the bundle bone is going to go, you will lose the whole buccal plate. We're going to try to see what we can do to try to reduce that. Bone regeneration, just a little bit of what we wanted to try to do is create an environment for the body to heal, and it will usually oblige. Okay, the body is programmed to heal. The body is programmed to heal. You have a cut, everything starts off, if you believe in the Almighty, or you believe in evolution, or both, or whatever you want to say, it is already trying to heal. We're trying to create an environment that will make it heal better. Yeah. To create bone, we need cells, signals, and we need a matrix of some sort, a scaffold. The cells come from the mesenchymal cells. They come from the marrow. They come via blood. That means you need oxygen. They're initially undifferentiated. They don't know what to do. Okay? The signals, which are the BMPs, the bone morphogenic proteins, help instruct the cells what to do. So the signals, if you create trauma, like an extraction, remember that an extraction is a trauma. It's a wound. Treat it like a wound. Don't just, when you take a tooth out, just put a swab over the top and go away and say, oh, hemostasis achieved. That is not enough. We have to treat a wound properly. Okay. The scaffold and the matrix is not the biomaterial. It is the collagen, the fibrin, the fibronectin, and the cell adhesion molecules that come into the socket. The biomaterial that you put in there will help create a scaffold and matrix, will help the blood clot. That is important to remember. Osteoconduction is when a material, a bone graft material, help create a scaffold matrix. They do not, an osteoconductive material does not induce bone. Osteoinduction induces bone. It will help differentiate osteoblasts into bone formation. And begin formation of new bone. This is really important to understand. Very important. Okay, and the only material that will do is living autogenous bone. That's the only thing that will really create osteoinduction. There are some papers coming out that saying beta tricalcium phosphate can induce bone. There are papers that show that. So I will throw that in there, that beta tricalcium phosphate can create bone. That means you can take a material, put it into another soft tissue, and bone will be created. So you could take the tricalcium phosphate, maybe put it into muscle, and bone will be formed. Okay, so this is important to know. Okay? The extraction socket is a wound. It should be treated like a wound. Okay, if you've got these two teeth are taken out and all this mess is in there, this chronic inflammatory tissue is in there, don't leave it there. Don't leave it there. There's bacteria in there. It all needs to be cleaned out, and fresh blood needs to be coming into that area to reduce the chance of septic sockets. That's better now. So we've cleaned everything out. We've taken all the granulation tissue away. There's going to be a better chance for good healing in that area. The extraction socket is a bone defect. Remember that. Because it's a bone defect, I would like to try to, in some way, augment it, to give it a chance to reduce the amount of defect. So the ridge preservation protocols, we extract. When we extract, we don't do figure of 8 anymore. We try our best to trisect, bisect teeth. We then clean the socket. We disinfect it. We clean by removing any granulation tissue that might be in there, any infected soft tissue that might be in there. We then disinfect. We then augment, if we're going to augment, yeah, and then we protect. Anyone, even if they're not going to augment, should be cleaning, disinfecting, and then protecting that wound. That's what I feel. Okay. Extract. We are trying to do flapless tooth extractions as much as possible. I've told you that this buccal plate is hard tissue, this buccal plate, most of the blood supply of that cortical plate, there's no trabecular bone there, very minimal trabecular bone. That means if the tooth is removed, as I repeated earlier, on the other side of that, the blood supply to the bundle bone came from the periodontal ligament. The periodontal ligament has now removed, so there's no blood supply on one side. The bundle bone will die. On the other side of the bundle bone is no trabecular bone, and then there is a cortical plate. The cortical plate, 100% of the venous return comes from the periosteum. 95% of the arterial return comes from periosteum. If you lift a flap, that will start to die. Because to create angiogenesis, we just put the flap back and we think everything's going to be all right. But no, we've removed all the blood from that cortical plate. We've removed all the blood from that cortical plate. Okay, blood supply, sorry. And that means that angiogenesis will be created in anything between 4 to 8 weeks, 4 to 6 weeks. And that means in that time, that bone will be starved of oxygen and it will die. Of course, it will die. Hence, you get the remodeling. We like to try to bisect and trisect teeth as much as possible. We even try to bisect single rooted teeth, or at least remove, because see at this angle, remove part of the tooth. That means this, if you put a luxator on the distal side of this tooth, it will fall it will fall into the gap of where you've removed the anterior part of the tooth. Okay. I use these instruments in 90 to 95% of my extractions. They are long beaked forceps, universal forceps, a root pick, and luxators. They're my standard. Remember, your luxators should be sharpened. It should be a sharpening tool. Okay. These are periotomes. I think don't start with these. Forget these. If you progress to implantology, then start to understand how to use these. I don't like using them because they take too long, but they're useful in some cases, but don't use them. When we clean the socket, we use a curette. It should be a serrated Lucas curette. And then we also have these degranulation stroke cortical decortication burrs, fantastic burrs. Okay. Another way of getting a nice Lucas curette is get a Michel's trimmer and get a very sharp burr and just serrate it around the edges. It creates some really nice sharp points and it creates a lovely serrated curette. We disinfect with blue M gel, of course we do. We must have saline, because saline has to be mixed. As another option is to, which I use a lot, is 50-50 betadine and saline. 50-50. It can't be neat betadine, it will kill the cells. Okay. When we augment, We can use autogenous bone, that is bone from yourself, allograft, bone from another human, xenografts from animals, synthetics, they come from a laboratory, and you get something like corals as well, and or seaweed, and then you have combinations. I sometimes use combinations because each material will do a different thing. It's not the scope of this lecture to go over that. Protect, Parasorb is brilliant. You get that from Swallow Dental. And Aura Aid, Copac you can get from us. Oh, sorry, not a Copac, you can get Aura Aid and the decarination burrs from us. Protect, you can protect using latex bandage, as I used to do in the past. A fantastic way of doing it. You can use light cured composite. Okay, but you can use Histocryl. Yeah. Okay. So, and sorry, also Aura Aid, which we can get from us. So we go into some cases now. Case 1. With a vertebral fracture on this 6 molar. I was going to place an implant in there, but still you could learn how to do part 1. You can see that vertical fracture. No, it cannot be saved. It's going to come out. I took the loose bit of root out, and you can see that very carefully. And you must pay attention to this case because there's something. There'll be some issues later. I then take this fantastic tri-hole burr, and I then decoronate the rest of the root. Once it is decoronated, I take that off, have a good look again, and then I will bisect this two-rooted lower molar. I will bisect right through to the furcation. It is important to understand, especially when you go into the lingual, try to leave this little sliver in place. Try and go through that because you'll go through the lingual plate, which could be very thin. And then I give a little twist with my luxator and you'll hear a little pop. Then I will go distally on the root and I will go right down the long axis and I will twist and I will ask Alexa to count 90 seconds. In that time, cytokaines, and there'll be some deformation of the socket, and the tooth will become loose. We know those root canal treated teeth are buggers to take out. They'll just keep breaking and breaking. Still even now to this day, they will do that. It became loose, and I took the teeth out in bits and had a good look at the tooth. Good look at the tooth. And I took, now that mesial root will fall in to the gap where the distal root has been taken out. And I again had a good look. I checked for my architecture of my socket. I then used my Lucas Correct to remove soft tissue. And you go down to the bottom of the socket and you clean it down from the top to the bottom, not down, go to the bottom, and you take out the granulation tissue there, the chronic infected tissue. I don't know why that's there. Oh, sorry, yeah. I had to lift a little bit of buccal flap here against my wishes, but because I was doing ridge preservation, I did not, wasn't too concerned. I used ethos here, which is mixed, and it placed it into the socket, which has been cleaned. I didn't have degranulation burrs then, I would have used that. Ethos is beta-type calcium phosphate mixed with calcium sulfate. A very good mix. I placed it into the socket, and then I placed some more into the socket, and then I got my Parasorb, my collagen sponge. This is an equine, highly knitted collagen sponge. You can actually squash it and it becomes very thick, and you can actually suture to it. Remembering that this collagen sponge will only protect for 3 to 4 days. The saliva will degrade it. So there's my ethos, which is set. I placed over the top collagen, my Parasorb, and then Looks a bit messy, but that was before. And that was after. I just took a check x-ray. And oh my goodness, I left a bit of root. So I took my check x-ray after I thought I extracted the tooth. I can't leave that there. Well, I could, but I can't leave that there because I'm placing an implant. So we mustn't be too cocky. I'm the best implantologist in the world. I'm not. Just a human being. That's all I am. We understand this educational pyramid. We must stay in the conscious competence area as much as possible. We must, at all times, as much as possible, drive the car, drive our dentistry with 2 hands on the wheel. We can't do our dentistry like that, because it'll come and bite us in the backside. And whenever I do that, it always does that. And it was in the picture. I was more interested in taking the picture than actually checking. So practice what you preach, Dr. Soni, practice what you preach. So I had to take the collagen sponge, I take the parasolve off, I had to take all the ethos out. I had to put another bit of more ethos in there, so it cost me £100. And then I sutured that down. Now this is a picture after about 10 days. And that's exactly what I want. That is granulation tissue in there. Perfect. That is now the body's bandage, and it's healing really nicely. This is me going and placing an implant about 6 months later. And we can see nice bone. This is living bone. And we can also see my implant be placed. This is, you can see this is turned over at 6 months, and this is 2 years, and it's completely turned over into bone. This is the kind of bone I like up against my implant. Bone that will turn over. We get fantastic results with synthetics or autogenous bone, and that is beautiful. Next case. Here I used a combination of, it's not ethos. Ethos is a beautiful material, okay, but I'm using this quite a lot now. We actually sell it, so it's good for us to use it, and we're getting good results with it. So it's a combination. We didn't use this neapatite, which is a non-resorbable hydroxyapatite. We used this beta-tricalcium phosphate, and we mixed it with calcium sulfate, medical grade calcium sulfate, to create a mix. Usually I mix it 50-50. These are fantastic little syringes you can buy. They're 5p each, and I just cut the end off. You get them Henry Schein, cut the ends off, and they become, and I get them ready for my ridge preservation. And these are filled with my mixture, or you can use ethos as well, or you can use autogenous, or you can use xenograft. Okay. I'm also preparing, so I've got my 50-50 betadine, I've got my protection, and I've got my Copac. I'm ready. In this case, we had a bridge. We tap the bridge off. Now I have my Essex retainer ready. And again, we'll go down the long axis of the tooth. I will go right down the long axis, and I'll twist, and I'll wait. I'll wait 90 seconds. Cytokines, and there'll be some socket deformation, and suddenly the tooth invariably comes loose. This is not a couplant, this is a luxator. It has to try to go down the long axis. Hence, if you can't get down the long axis because the tooth next to the root you're trying to take out is very close, then you must create a ferrule around the tooth. Create that with a burr. You go just underneath the soft tissue. You do not go down to the bone. The roots came out. And again, sometimes you go down the long axis, you're finding it very hard, especially on older patients, to get down that bone because it's quite brittle. Then I just sometimes use a tap down the long axis. It's just a gentle tap, and out came the next root. Invariably, about 80% of my teeth come out on their own, meaning I twist, I wait. I don't twist like that, I just twist about 20 degrees, 15 degrees, 10 to 15 degrees, and I wait. There's deformation. I'm checking if there's a buccal plate. Good. If there's a full buccal plate, I do not need to have a membrane. Even though calcium sulfate is a membrane, and that's how I use that. So I've got a membrane within my material. We've got degranulation burrs. So in this case, there was minimal soft tissue, so I didn't need to use straight to curettage. I went straight to the degranulation burrs. If there's a lot of soft tissue, don't go to the degranulation burrs straight away. You'll create a mess. I then, once it's degranulated and slight decortication, not on the buccal plate, decortication around the rest of the tooth, I then took the 50-50 betadine saline mix and I plugged it into the sockets, and I waited. I asked Alexa to play American Pie or Stairway to Heaven, anything about 6 minutes, 7 minutes, okay? And I wait. Then Alexa's trying to speak. Then I will take the cotton rolls out, and I will wash with saline in those sockets. Okay, I then took my mix, which was ready from the start, and again, as I said, it's surgiplaster and beta tricalcium phosphate in this case, and I would push it right into the socket, filling the socket out as much as I can. And I would push a plugger into the socket and really fill that socket up. That is nicely filled. I'll then take my Aura Aid. Sometimes when you take the Aura Aid, the plaster off the plastic, it's hard to know until it touches water, which is the sticky bit, which is not sticky bit. So there's no harm in putting a little black spot on the non-sticky bit. You took it off, I adapted, and then I would suture this into place. And you can see now it's sutured into place. Okay, you suture it with a 5/0 suture, and you just gently go through, twisting the suture. And if you come to the hands-on, we'll do some practicing with that. And then my Essex retainer on top. Beautiful, beautiful. And I'll try to show the CBCT in 6 months' time on my Facebook, and you'll be able to see bone regenerated in that case, hopefully. Next case. So we've got a tooth, the crown that's come off. There was a fracture in this underneath this tooth. There was an area, so we decided to take this tooth out. So again, usual principles. You can say do this yourself. Now I've split. I've not gone through that. I made a little sliver there, gone down the electric long axis, and now try to take a little bit more out in between, because as this moves forward, this tooth will get in the way. As this mesial root falls into the gap of the bifurcation, the distal root will get in the way. Again, a little tap tap, and it was breaking root canal tooth, and it came out. Again, I twist, and it would come out. Again, we got nice socket there. Buccal plate is present. I will then degranulate with copious saline. Degranulate at 1200 to 1600 RPM, depending on what type of bone it is. Higher with harder bone. Copious saline. You don't want to overheat this bone. You can see that's nicely clean now. Really nicely cleaned. I take my 50-50. In this case, I used Physiograft. Physiograft is a polylactic and polyglycolic polymer. I use this when I definitely have a full socket available. Okay. The scope of this lecture isn't should I use one or the other. I would not use this if the buccal plate was missing. I would definitely have to use something with a membrane, or the membrane included, like calcium sulfate. We open the bottle, and it comes in this quite hard form. We just add a little bit of amoxyl liquid, just dampen it, and we then push it into the socket, and you just place a luxator over the top, and you just put downward pressure. It will deform, and it will form fully into the socket like that. Beautiful. Again, I would get my aura aid, and I'm suturing my aura aid into place. And then I do my second protection. Last case. Patient came, sadly fell outside the surgery on a paving stone. Not that I did not lift that on purpose, that paving stone. The tooth had to come out. Again, I will just go down the long axis, twist and wait. There'll be cytokine release, and there'll also be deformation of the socket. Wait. I will then check for the buccal plate. I will use my degranulation bits. Everyone must learn these skill sets. Everyone must buy these small little instruments. They will help you. They will improve your skill sets. I know more and more people coming out of university not having taken lots of teeth out, especially in the last 2 years. It's quite sad what's happened with COVID, etc. But you must learn how to take teeth out. Patients want you to take teeth out. They don't want to be referred. They really do. They want you to do as much as possible. I added my 50/50. I added my ethos here. I then took my collagen sponge. I squashed it, as I said before, and I placed it over the area. And I did a cross suture over the top. This can be 2 interrupted sutures from one angle to the other, or it can be 1 continuous cross suture, which we can show you how to do. I then put saline acrylate over the side of the on the outside, on the inside of the pontic. Why? Because even though that's a fantastic collagen sponge, highly knitted, it will resorb in 3 days, maybe less. The cheaper ones that you get, the Rayco ones you get, Roco, and the other collagen sponges won't even last a day. The enzymes in the saliva will remove them, will degrade them. This is 2 weeks later. And this is what I'm trying to say. Even if you're not doing implantology, we want to try and keep some of this architecture, try and keep some of this buccal wall. If you're not going to do, if you're not going to do an implant in there, which we decided against it for whatever reason, then I would use a very slowly resorbing material in there, like a xenograft or a non-resorbable hydroxyapatite neoapatite. Like neoapatite, sorry. That would be better long term. So we're going to be, contact us if you want to learn about this great skill set to have. And feel free to contact me. I hope that was useful. Please contact me anytime. My phone number's there. Just email me on that. Thanks, Ajay. Thanks, Dr. Mehta, again, for your asking me to do this short lecture. It's a full day of hands-on if anyone wants to learn any more. And well done to everyone supporting this great course. And if you see me walking around somewhere in a conference or whatever, or in a pub where I can be a lot of the time, just come up and say hello. We'll have a good banter. All right, stronger together. Look after yourself, and hope everyone's all right out there. Okay, bye.